So we're going to talk about hyper and hypocalcemia. And this is from the point of view of management, not so much from the point of view of diagnosis. So you see this all the time in the consult service. And you know, in a way it's very straightforward, and in another way it isn't. You know, we know what the clinical features of hypercalcemia are. There are constitutional features. They don't feel good. And then in specific terms, why don't they feel good? The central nervous system can be depressed to a point of altered mental function, to a point of true coma. And there have been examples in the past of life-threatening hypercalcemia associated with, semi-coma or someone who's really in coma. But there may be no CNS symptom whatsoever. The gastrointestinal tract, we have the upper tract, the lower tract. So the nausea, the vomiting, the anorexia, and the constipation are classical manifestations of hypercalcemia in the GI tract. And then the renal system, the most prominent clinical symptom is polyuria. When I took my boards, there was a question that led you right down the garden path to diabetes. Someone was complaining of weight loss, polyuria, polydipsia, and if you went down that garden path, you would get the wrong answer because it was not diabetes. It was the hypercalcemia of symptoms. So polyuria, polydipsia are very, very common when hypercalcemia becomes symptomatic. And then the cardiovascular system, it can be affected, and we know the classical electrocardiographic abnormality of a shortened QT interval. Now, although those are symptoms, they don't directly relate to the serum calcium. In that, I mean that the serum calcium can be not that high and a person could be symptomatic. On the other hand, a person could be rather asymptomatic with a serum calcium that is in the range where you'd expect patients to be symptomatic. So this absolute serum calcium, corrected serum calcium, doesn't always predict symptoms. More important is how rapidly the serum calcium rises. The faster the rise, the more symptomatic the patient will be. I had a patient, there are a lot of NIH analogies today. I don't know, it's because you're here. I'm thinking about all my NIH stuff. But I had a patient who was a regular NIH research patient. He lived in New York, and he took the train from New York to DC, and he had parathyroid cancer. Comes in for his regular, every 3 months he would show up, and his serum calcium was 20. Corrected serum calcium was 20. And I said, how do you feel? He said, I'm okay. I said, do you have any symptoms at all? He says, I'm a little bit more tired than usual. Now, why was he essentially asymptomatic with what ordinarily would be life-threatening hypercalcemia? Is because he had lived for years with parathyroid cancer, and his average serum calcium was like 15. So going up to 20 wasn't such a big deal for him. And then how long the serum calcium has been elevated. And this last point is, we don't know. Everybody's different. Some people tolerate hypercalcemia well, and some people don't. So when you get a consult for hypercalcemia and management, it isn't so reflex, serum calcium is whatever, we must do this or we must not do this. It really is nuanced by how the patient presents. Yes, the serum calcium is important, but there are these other factors that you have to take into account. Now, there are, in sequence, 4 pathophysiological steps to acute hypercalcemia. The first, obviously, is that there's got to be a stimulus for that serum calcium to increase. And it almost doesn't matter what the etiology is. There are some exceptions. But it's usually the osteoclast that has become activated or more activated. And that activated osteoclast is going to resorb bone at a much higher rate than usual. The second is the extent to which the renal tubules can conserve calcium or not conserve calcium. So when you have a stimulus like parathyroid hormone or PTHrP, those renal systems are going to conspire, if you will, to conserve the serum calcium and to further aggravate the hypercalcemia, as opposed to a non-parathyroid hormone-dependent hypercalcemia, in which there would be a greater degree of hypercalciuria for the level of the serum calcium. So actually, PTH and PTHrP, for the same level of the same stimulus, would be more likely to lead to hypercalcemia than some other etiology. And then the GI tract sometimes, if it's a vitamin D-related mechanism, yes, the GI tract will be participating. But even in vitamin D-mediated hypercalcemia, the real culprit is the osteoclast activation. And then finally, in people who are not ambulatory or become less ambulatory, that of course will induce further skeletal mobilization. So those are the kind of the factors. And then the hypercalcemia becomes symptomatic, and polyuria, polydipsia are stimuli to keep the serum calcium normal, if you will. But there's going to be fluid losses, and so the need to drink is going to at some point be overcome by the anorexia. The anorexia being a feature of the central nervous system actions of the hypercalcemia. And when the anorexia sort of becomes part of this, then patients become dehydrated. So you have ongoing renal losses of fluid, and you aren't keeping up with the fluid needs. So then patients get dehydrated. And then once dehydration ensues, then you see the plasma volume constricting, clearance is reduced, and the serum calcium can rapidly go up. So you, I'm sure, have had situations where the patient's serum calcium was okay, and then 2 days later, it's 15 when it was only 11 or 11 and a half. So that's kind of the pathophysiology of the development of acute hypercalcemia. All right. So getting back to the numbers, here are 3 to think about. If the corrected serum calcium is less than 12, it's my view that it's hard to attribute symptoms to hypercalcemia. Now, there are many services that you will be consulting on. You've already had this experience. Well, the calcium's 11.8 or 11.5, and the patient has altered mental status. It must be that. And the problem with that thinking is it usually isn't. And if you go after this as the etiology, you're going to miss something more important. So don't get distracted by an obvious explanation. Think that there might be something more to it. My mentor taught me a great lesson once when he said, a patient can have fleas and lice. There can be more than one thing wrong with a patient. All right, now, the level between 12 and 14. Then that's a never land. Yes, patients can be symptomatic when the serum calcium is between 12 and 14. But they may not be. So you need to think this through, and you need to use your clinical judgment. And you can't be, don't be influenced by people who know less than you. If you don't think it's symptomatic hypercalcemia, stick to your guns and say, we don't think that's it. I'm not saying you wouldn't manage it in some way, but you wouldn't attribute the symptomatology to that absolute level of serum calcium. And then finally, when the corrected serum calcium is greater than 14, then you're, even though the patient may be seemingly okay, I think you're pushing the envelope if you say a serum calcium of 16 with symptoms is not related to the serum calcium. It may not be, but it becomes less and less likely. So those are kind of broad stroke thoughts about how you would regard the serum calcium in the context of symptomatic hypercalcemia. Okay, so we have general measures and we have specific measures. These are the general measures we often do. Obviously, rehydration is very important because these people are typically dehydrated. And the fluid of choice is saline because by giving saline, you will induce a saluresis. And as the kidneys are dumping salt, they will drag the calcium along with it. So you'll induce a calciuresis by administering saline. You have to be careful, of course. It depends on the age of the patient and what the cardiovascular tolerance of saline administration is. So just doesn't put a bag up and start 250 cc's an hour. You just, you have to understand what else is on with the patient. Now, loop diuretics like furosemide will help you administer more fluid in a smaller period of time. You can use furosemide after you have first rehydrated the patient. I tend to be cautious with furosemide. I mean, you do have to there are issues with regard to magnesium and potassium, but you can use the loop diuretic. Dialysis, if you're really up against it, you can do. And then as soon as you can get the patient out of bed and moving around, of course, that's good. But all these are very general, first-line approaches. But that typically doesn't do more than drop the serum calcium by 2 milligrams percent, maybe 3. But you almost never are going to normalize the serum calcium with just these measures. So, what do you want to do? You want to do something to this osteoclast, because this is the culprit. And if there's some way to inactivate this osteoclast, render it dysfunctional, or kill it, you will block the inciting pathophysiological event to mobilize calcium from bone. And so what we have are a number of agents. The bisphosphonates are the first, second, third choice. Those are the drugs we use. I'm going to make a couple of comments about the two drugs in lowercase, Plicamycin, that you've never heard of, I'm sure, and calcitonin, and then glucocorticoids and the underlying etiology. Okay, so the bisphosphonates, they're going to come back over and over again over the next 2 weeks in many different contexts. The two that we are going to be attending, I'm sorry, what happened here? Well, whatever. It was supposed to be, never mind. The two we're going to be talking about are zoledronic acid and pamidronate, because those are the two that are available intravenously. Abandronate is too, but we don't use abandronate for hypercalcemia. These are very, very potent molecules, as all the bisphosphonates are. The amino-substituted bisphosphonates are represented by zoledronic acid and pamidronate. The others, risedronate, abandronate, and alendronate, also are amino-substituted bisphosphonates. The amino substitution gives them much greater potency, and we'll talk on Thursday. They use a different mechanism than the atidronate, clodronate, Zoledronate drugs that used to be available for this purpose and for other purposes. Okay, so they are osteoclast inhibitors. They are specifically effective to render the osteoclast dysfunctional, and to a certain extent, the bisphosphonates will literally kill the osteoclasts. You have to use the intravenous route if you're using these drugs for the treatment and management of hypercalcemia. They don't work immediately. There is a little bit of a lag, anywhere from 24 to 36 hours after the first dose. So you don't expect the serum calcium to respond over and above the rehydration effect until the first day is passed. And the duration of effect is variable. Sometimes you have a long-lasting effect, and other times, again, depending upon the aggressiveness of what is the case. If it's a severe malignancy with lots of metastatic disease, you may not be able to hold the patient for very long. On the other hand, if it is the acute hypercalcemia of hyperparathyroidism, one shot of Zol might do it, get her back to where she was. And here is what I was pointing out: zoledronic acid and pamidronate. And you know, we use zoledronic acid. I'm sure all of you do. That's the drug that we use. And here's an example of the kind of effects you would expect with pamidronate, but zoledronic acid gives you the same nice excursion downward over a period of 2 to 4 days. And this was a head-to-head comparing zoledronic acid and pamidronate. There are 2 doses of zoledronic acid. You really can't even tell because they're superimposed on each other. But what Zold gives you is a somewhat greater effect than does pamidronate, and the effect is more long-lasting with the 2 doses of zoledronic acid. So most of us will use zoledronic acid as the bisphosphonate of choice. The effects of zoledronic acid in this context are sometimes the acute phase reaction, and you need to know about that because the patient becomes febrile, and whatever the underlying condition is, there might be some worry about an infection or what have you, and there might be, but it could well be just as a result of the acute phase reaction of the zoledronic acid. The white cell count can drop a little bit, the phosphate can drop a little bit, and the actually quite a worrisome possibility is that you give too much. And we've had situations, not recently, but we've had situations where we have given zoledronic acid 1, 2, 3 doses, and then the serum calcium has dropped from 15 to 5. And then you're in the embarrassing situation of having to give calcium. So you have to be careful. These are very potent agents. Now, Plicamycin is a drug that we used to use. I do this just for historical reasons, and also I have a point to make about this. Plicamycin is also an osteoclast inhibitor. It's used intravenously. It works a little faster than the bisphosphonates, but like the bisphosphonates, the effect is variable. So this is what I wanted to show you. This is from the Annals of the Presbyterian Hospital, 1983. And this was a man in his 70s who comes in, brought in by his granddaughter, and the complaint is, I don't feel good. And his serum calcium is 26. Now, there are 3 data points here: 26, 26, and 26. It was repeated. His calcium was 26. And he was given a dose. In those days, we didn't have the bisphosphonates. The bisphosphonates we've only had since, really to be used since the 80s in this regard. So he got Plicamycin, got 2 doses. And you can see how nicely his serum calcium came down. He was rehydrated. He never got any diuretics. Now, on the service in those days was a young, brash house officer who was now the CBS News TV doc, Jonathan LaPook. You know Jonathan LaPook? You don't know Jonathan LaPook? You listen to the radio? TV? No. Do you have a TV?
I do.
Okay.
It's rarely on, though.
Jonathan LaPook is the guy who reports on all the medical things. He went to Brazil for the Zika virus. He goes all over. He's a gastroenterologist, was here for many years, and just 2 years ago bolted and left us to go to NYU. Jonathan said to me, the guy has cancer. I said, what makes you think he has cancer? And Jonathan said, look at the serum calcium. I said, well, wait a minute. He comes in and he has no history. He's feeling well. And then he's not feeling well. And he comes in and he has a... So I said, I think this guy might have hyperparathyroidism. To which Jonathan says to me, serum calcium's too high. Don't forget the comment. The serum calcium is too high for primary hyperparathyroidism. The highest levels of serum calcium in the history of the universe have been reported in primary hyperparathyroidism and in children. I think there are levels up to 32. There's one in the pediatric literature where I believe the serum calcium was like 30 or so. So don't ever say the serum calcium is too high for hyperpara. Okay? So what happened to this guy is he, is down here for a while, and then his calcium creeps up a little bit, and here, 2 weeks later, he's in the hospital. In those days, you could stay in the hospital for 2 weeks. He had his curative parathyroidectomy. Okay? So it's a wonderful case. And we don't do cases like this. But, I mean, when you see really big league hypercalcemia, do not rule out acute hyperparathyroidism. What triggers the mild hypercalcemia of hyperparathyroidism to be transformed to an acute event? I have no idea. I mean, we have some ideas. Patient could have gotten sick and wasn't ambulatory. A patient could have had a virus, could have become dehydrated. Some people think that the adenoma could have infarcted, could have had some bleeding, and had an acute outpouring of parathyroid hormone. These people actually do not have super high levels of PTH. It's not like they've gone from 100 to 1,000. So it really isn't clear what are the inciting events that lead to acute primary hyperpara. But anyway, don't forget that this is the kind of a classic case of acute hyperparathyroidism. All right, calcium. Yeah.
Why do we not use that anymore?
Plicamycin, yeah, good question. Why don't we use plicamycin? Yeah, it's a good drug. It's a really good drug. Yeah, there are some problems with this drug. It was used as a chemotherapeutic for, I don't know, some bad cancer. And it doesn't do good things to your white count, to your platelets. Things go in the wrong direction. People can become thrombocytopenic and very severely leukopenic. And so as the bisphosphonates became more widely used, plicamycin basically is not available and not used. But it's a little bit like Vioxx, Vioxx is a great drug. The trouble is it kills you, but aside from that, it doesn't kill you. In short term, it's really a wonderful non-steroidal. Because of the history of Vioxx, it's not available. About 5 or 6 years ago, before it was taken off the market, I came in. I almost never get back pain, but I came in one day and I was like, so Shawnee comes to me and she has a 50 milligram tablet of Vioxx. She says, take this. So I took it and I did not have another twinge of back pain for 10 years. Fabulous. It's a fabulous drug. So, okay. So calcitonin. Now, calcitonin should be really a good drug for hypercalcemia because beyond its anti-osteoclast actions, it's a calciuretic. So you're going to increase renal losses of calcium as well as blocking egress of calcium from bone to blood. You can give IV sub-Q, very benign, and you get a very rapid, it's the fastest acting agent, short of phosphate, which you're not going to use. And within 12 hours, you're going to have an appreciable drop in the serum calcium. The bad news is that it's relatively weak and short-lived. So here's the typical experience with calcitonin. In a couple of hours, the calcium will drop by a couple of milligrams %. And that drop is probably due to the the calciuric effect, not necessarily to the calcium effect on the osteoclast, because that takes a little bit longer. So it's probably a renal effect that allows the calcitonin to have that rapid action. But it's not a big effect, and it doesn't last that long. So you've got the bisphosphonates that are much more potent than calcitonin, but you have calcitonin that works faster. So why not use both? And I think, do you use combination? Yeah? You like combination? Yeah, we typically use calcitonin and zoledronic acid, taking advantage of the rapid action of the calcitonin and the slower action, but the more greater action of bisphosphonate. And that's the rationale for combination therapy for hypercalcemia. And this goes to the old days when we would use combination therapy. The initial effect, we believe, is a calcitonin effect, and the later effect has to do with the actions of these agents to inhibit the osteoclast. Glucocorticoids. There are certain situations where glucocorticoids can be very effective in the management of hypercalcemia. Any vitamin D related hypercalcemia will be sensitive to steroids. Multiple myeloma, if you know it's multiple myeloma, can be very sensitive to steroids. And certain cases of breast cancer, willy-nilly, not known, but some patients with breast cancer and hypercalcemia will respond well to glucocorticoids. Hyperpara typically doesn't respond to glucocorticoids, but these other conditions do. So if you know what the etiology of the hypercalcemia is, and if it's a lymphoma, if it's a vitamin D, if it's a myeloma, the first line agent would be glucocorticoids, would not be bisphosphonate. And then finally, if you know what the underlying etiology is and can manage it, you would go after that as well. And it does, yeah?
How high can your calcium get with vitamin D toxicity?
Very high, very high. How high? The highest I've seen with vitamin D toxicity, I saw a patient whose serum calcium was 16, 17. Yeah, you can have major league hypercalcemia. The vitamin D toxicity is usually associated with a hyperphosphatemia, and that's really dangerous because then you have the calcium phosphate product that is exceeded typically with vitamin D toxicity. Michaela will talk to you tomorrow about the calcium phosphate product in hypopara, when patients are given calcium and their phosphates are high. But yeah, have you seen, what, you haven't seen it? Has anybody seen vitamin D toxicity? Nobody. Any of you heard of Zoledronate? You have heard of Zoledronate, but you haven't heard of...
And the challenging cases she presented, so
Yes.
the first lecture.
Yeah, yeah.
Question about rehydration. When you do it as outpatient, do you recommend a certain type of oral fluids, or you just say free water? Because I've seen some people do free water with salt tablets, but I don't know if you have oral fluids that you recommend as outpatient.
Yeah, well, it's a good point. When you get to the point of that kind of situation, do you really want to manage them as an outpatient? You have to use an oral route. I mean, you're not going to give them an IV at home. And if you use an oral route, you have to give them water, free water. and that's not nearly as effective as saline IV. So I think if you're at that point, I think the better part of valor is to bring them in and rehydrate them intravenously. So I can't remember a situation where I managed somebody who, like that, on the outside. It's not easy. And then you could really lose ground rapidly with these people. So I wouldn't advise that. Kind of stuck, yeah.
Have you had any adverse reactions to giving calcitonin?
I haven't. It is recommended that you do a skin test. When we are dealing with acute emergent hypercalcemia, I don't think we do give a skin test. Do you do skin testing? I mean, the package insert says you should. Has anybody had allergic reactions to calcitonin? It is theoretically possible. But I think it's, I guess if you had a patient who has really had an allergic history, you might take a little tiny bit and give it sub-Q. Mohammed?
Does the effect of steroid has long-term effects or it's reversible? So if we stop, the effects will go away, like the calcium level will shoot up after stopping the steroid?
I'm not hearing you, I'm sorry.
Saying how long-term is the effect of the glucocorticoid?
Oh, yeah, sorry. How long is it? Oh, well, it varies. If it's myeloma, steroids is part of the therapy, I think, part of the chemotherapy. So it's a myeloma. Boy, you can have the serum calcium drop from 16 to 9 in 2 days and stay down there because you're getting an anti-tumor effect as well as the anti-calcemic effect. And other patients, depends, I mean, if it's vitamin D toxicity, you'll have an effect, but it depends on how much vitamin D is in the system because the patient can escape. So I really can't know. It really depends. And by the way, that reminds me of one thing. We have had several patients who came in with multiple myeloma, known myeloma, and their serum calcium was 18, 19, and they were completely asymptomatic. Completely. What would you think in that case? Right. So you measure the ionized calcium, and it's normal. And the reason why they're hypercalcemic is because the myeloma protein is a calcium-binding protein. And that's what you're seeing. But it has very high affinity for calcium. It doesn't, the partition between total and free, which is usually 50-50, is no longer 50-50. It's like 80-20. So beware of myeloma and hypercalcemia, because there are, and we have actually published on this, there are not, most myeloma proteins are not calcium binders, but yeah, you may find one. So just, that should cross your mind. There's a situation where I would measure, I'd call you up, and you'd measure the ionized calcium for me. There's a situation where an ionized calcium would be extremely helpful to prove the point that this is not true hypercalcemia. Okay.
Bilzekian, one more question. Just for the glucocorticoids and say sarcoid, do you have any thoughts on how long to keep somebody on steroids for?
Yeah, I don't know. If it's for hypercalcemia or for something else.
For hypercalcemia.
Again, we haven't had a lot of experience. I've had only a few patients who had really high serum calciums with sarcoid. Hypercalcemia is common, but not to where you'd be treating them like this. So I don't know. I don't have enough experience to know what you would expect. Again, do any of you, have you seen majorly hypercalcemia with sarcoid?
I actually have 2 patients, and the only literature I was able to find, well, nothing for calcium, was just trying to follow the recommendations for pulmonary sarcoid.
Yeah.
Which is to keep them on for
Yeah.
6 months.
Yeah, that's different. Yeah. So sure. the recommendation for pulmonary sarcoid and steroids is very different. I don't think there are any guidelines for hypercalcemia and sarcoid. But typically, again, the serum calcium is, I don't know, milligram or so. Remember also in sarcoid, hypercalciuria is very, very common. So that is protecting them a little bit from the disposition to become hypercalcemic. Okay. All right. So let us go to hypocalcemia. And hypoparathyroidism is one of the etiologies of hypocalcemia. And obviously it's because of deficient secretion of parathyroid hormone. And then there are the hypocalcemias associated with secondary hyperparathyroidism. Now typically, patients who have secondary hyperparathyroidism, they're responding to an appropriate hypocalcemic stimulus. And often, the serum calcium is really not frankly low, but in the lower range of normal. But sometimes it is frankly low. For example, in vitamin D deficiency, classical vitamin D deficiency, the serum calcium is low normal. The phosphate is low normal, and the PTH is very high. But we do see situations where there is frank hypocalcemia, and there's a very easy differential here between hypoparathyroidism and secondary hyper, and that is simply measuring the PTH. And then there's a whole host of other causes which we'll talk about. So the differential diagnosis, here's my little diagram, which I love. So this is the box of normality, and this is this wonderful relationship between the calcium and the parathyroid hormone. It's extremely steep. So over this range of normal for calcium, the PTH will move very quickly up or down, depending on the patient and the acuity with which the calcium may change. In hypoparathyroidism, you have a low calcium, and the parathyroid hormone level is low. So it's very easy. If the calcium is low and the PTH is low, you have a hypoparathyroidism. I'm not saying you have hypoparathyroidism in the classical manner, but you have a hypoparathyroidism. And then you have the secondary hyperparathyroidism, where you can have hypocalcemia. This little cartoon should morph into the normal range a little bit better, because often these people have low normal serum calciums. Okay, so if the parathyroid hormone level is low, the diagnosis is hypoparathyroidism. However, in some of our inner city populations, we will have a hypoparathyroid state because there is hypomagnesemia. And typically in alcoholics, the magnesium can be low, and they can appear as if they had hypopara. The serum calcium is low, and the PTH is low.
Dr. Bilzekian, how low does the magnesium have to be to impair PTH?
Yeah, so it has to be either has to be chronically low, and then in that case it probably doesn't matter. But if it's acute, it's got to be below, with a normal range, but it has to be below 1.6 milligrams per deciliter. And if you get down to 1.4, 1.2, that's really where you, because you're just pointing out a good point, which is typically a drop in the magnesium will stimulate PTH. It's a divalent cation, just like calcium. So the parathyroid gland responds initially to a drop in magnesium with an increase in PTH. So the paradox is a little bit paradoxical, that low magnesium impairs parathyroid hormone in several different ways. It impairs the secretion of PTH from the gland, and it impairs the synthesis of parathyroid hormone. And it also impairs the activation of 1,1,25-dihydroxyvitamin D. Okay? Compensatory hyper, we've talked about vitamin D deficiency, all kinds of ways you can get vitamin D resistant, nutritionally, liver disease, I'm not resistant, deficient, liver disease, renal disease, the vitamin D resistant states, some drugs that can be associated with vitamin D deficiency with secondary hyperpara, and then you have pseudo, which is a classical example of a secondary hyperparathyroidism. And so here are the hypoparathyroid states, here are the hyperparathyroid states, both associated with low calcium. So the differential diagnosis of hypopara, we probably oughtn't to put autoimmune disease at the top because it's not the most common cause of hypoparathyroidism, but it's perhaps the most interesting, related either to multiple end organ deficiency of the endocrine glands or to isolated parathyroid hormone gland deficiency. But the most common is post-surgical hypopara. And about 75% of patients with hypoparathyroidism will have post-surgical hypopara. And the post-surgical, it can be after thyroid surgery, of course. It can be after parathyroid surgery. It tends to be more common in centers where thyroid cancer is very common and treated, because then more radical neck surgery. It's also more common in centers that are more aggressive in terms of neck surgery, even for benign thyroid disease. And even in parathyroid disease, there are centers, there's only one in this country that I know of, that typically would do an open four-gland exploration. Most of us don't approach hyperparathyroidism that way. But if you approach it that way, and you are thinking that there's more multi-gland disease than there really is, then there can be more frequent post-surgical hypopara. And then certain countries, like Brazil tends to be more aggressive in their parathyroid surgery than other countries, and so there's a fair amount of hypoparathyroidism, disproportionate in Brazil. And then there are these genetic, very rare hypoparas, these familial diseases where there's a parathyroid gland, but the processing of parathyroid hormone as a gene product is defective, or the cell can't get the parathyroid hormone out of itself. It just can't, the trafficking system is not working. And of course there's developmental agenesis like the George's syndrome. Activating mutations we've talked about, activating calcium receptor antibodies we talked about, and then the pediatric syndrome to George, where some of these kiddies are growing up to be adults, right? The disease is not only a pediatric disease. And then there are the conditions where parathyroid hormone is suppressed, but not because of the autoimmune disease and not because they don't have any parathyroid glands. And the magnesium deficiency, we say severe, is the best example of this. You can actually cause a hypoparathyroidism due to magnesium excess as well. We discovered this on the wards, the maternity wards of this great hospital. We were being called for pregnant women in labor, but they were being given magnesium to control their labor, and they were developing carpal pedal spasm, and they were hypocalcemic. Their parathyroid hormone levels were undetectable. But their magnesium levels were in the toxic range. The obstetricians were just giving MAG until labor ceases. And not exactly a good idea now that we know that you can become really magnesium toxic in this setting. So you have to be careful. We had another example, not so much of hypocalcemia, but with magnesium excess. We had a patient who came into the hospital. It was a Saturday, and he was a type 2 diabetic, and he was tended to take mag citrate for his monthly clean-out. He seemed to like to do this. So one day, the one bottle wasn't enough, and he took at least 2, maybe 3. And he comes in to the emergency room saying he doesn't feel good. And he has a cardiorespiratory arrest. So he's resuscitated, and he's brought to the ICU, where his EEG shows an EKG artifact. You see the EKG in the brain, EEG, but there's no other brain activity. So he's had a cardiac arrest, he's been resuscitated, and he's brain dead. Maybe. So we got this history that he had taken 3 bottles of magnesium. And we know what magnesium can do to the brain. It can suppress the brain. So we didn't have access to stat magnesium tests in those days. So we agreed that we would definitely keep him going until Monday, and then make sure what his magnesium was. And it was 20. His magnesium was 20. And the guy, of course, then he was dialyzed, and he had a complete recovery. Complete recovery. It's amazing, isn't it? So, all kinds of interesting things like that. This guy, I don't remember whether his calcium was low. Nobody cared about his calcium. I don't know what it was, but whatever. Okay, so then infiltrative disease are very rare, very, very rare. And I-131 therapy for hyperthyroidism is really, really unusual. The parathyroid glands are very radioresistant, even though you would think that the I-131, the parathyroids are right next to the thyroid. It should, have that energy and be dangerous, but it almost never happens. Okay, so here's the story with magnesium deficiency. This is a patient that, again, very old patient, but it's a wonderful example. A patient who is an alcoholic comes in, and he is hypocalcemic, as you can see, for about 2 weeks. And then he had a lot of things wrong with him. And then somewhere along the course, somebody recognized that he had hypocalcemia. And he got calcium, lactate, he got vitamin D, and you can see nothing happened until his magnesium was first measured. And you can see in this case, he was less than 1. And then he was given mag sulfate, and you can see what happened. His mag comes up nicely, and his calcium is following a little bit later, and then eventually comes up to normal. So this is a wonderful example of the hypoparathyroidism of magnesium deficiency. And what happens is when you give, in this setting, when you give magnesium, it's very interesting. Almost immediately, this is in minutes, you see an increase in immunoreactive parathyroid hormone. But it takes, in fact, you can't even tell in this little short graph when the serum calcium will rise. So it'll take longer for the calcium to go up, even though you've unblocked that parathyroid secretory effect of severe hypomagnesemia. The PTH comes up nicely, the MAG comes up, but the calcium will stay down. That's why in hypomagnesemia, you have to treat not only with magnesium, but also with calcium to tide them over. So you have impaired parathyroid hormone secretion in magnesium deficiency. You have an end organ skeletal resistance to parathyroid hormone. And in addition, there's impaired 1,25-dihydroxy. So the goals of therapy are to alleviate the signs and symptoms of hypocalcemia, to correct the hypocalcemia, to correct the associated hypokalemia, which is very classic part of this syndrome, but not to replace the total body magnesium deficit. You're not going to do it, or you shouldn't do it, in terms of parenteral magnesium administration. If you give IV magnesium, 90% of it will be cleared by the kidney. If you give IM magnesium, you're being punitive. It really hurts. You have to give it, but you're not going to give that much, just enough to tide them over. Okay? All right, so the pseudo-hypo we won't talk too much about. This is just, again, a common disease at the NIH, but we don't see very many here. This is a very interesting example of four sisters with pseudo-hypoparathyroidism. And they had the brachydactyly, you have the round face, the short squat neck. They had seizure disorders. Their intelligence was not the greatest. And that's the way they presented. This is their foreshortened metacarpals. And then there's a whole host of other, we talked about osteoblastic metastases that can present with a hypocalcemic emergency. There's this hypocalcemia of severe illness, which has never really been explained, but people in the ICU will typically have mild hypocalcemia and the like. And sometimes citrated blood transfusions will complex the free calcium. Okay, so the clinical features of hypocalcemia, obviously neuromuscular irritability, paresthesias, Chvostek sign, Trousseau sign, prolonged QT interval, and then the spasms, the carpal spasm, the pedal spasm, bronchospasm, laryngospasm, and even to the point of seizures can be part of the syndrome of the neuromuscular irritability of hypocalcemia. So this is the Chvostek sign, and you tap on the facial nerve and the ipsilateral seventh nerve will get irritated. If you do this test in Brooklyn, you'll have many positives. This is called a Brooklyn facial. And actually, 10% of normal people have a positive Chvostek. So it's not the most reliable sign. Much more reliable is the Trousseau's, where you raise the blood pressure above systolic and keep it a little bit above systolic for a few minutes, and then you'll see the carpal spasm. And this is the example of the carpal spasm that you get with the Trousseau sign. So, like hypercalcemia, the determinant of clinical signs are variable. How severely the hypocalcemic the patient is, obviously, the more likely there will be symptoms. We've had people, though, who've had calciums of 5 and 6, and they're not really symptomatic, and others who are not happy if the calcium is below 8.5. If the calcium is rapidly reduced, you can see symptoms of hypocalcemia. We had a patient once who had developed symptoms of tetany with a serum calcium of 12. And the reason why she became tetanic with a serum calcium of 12 was because she had just had parathyroidectomy for acute hyperparathyroidism, and her serum calcium had been 22. So she dropped from 22 to 12, and she was symptomatic of hypocalcemia, although she wasn't hypocalcemic. And the duration is a factor. Some people do get acclimatized to it. And the individual variability, as I mentioned before. Okay? So the acute management, you're going to deal with the symptoms. If they are symptomatic, you are going to treat. If they don't have symptoms, there's a point below which, just like with the calcium, above which, you're going to treat. And if the corrected serum calcium is less than 7.5, it varies, but that's sort of a threshold where you would be wanting to replace the serum calcium more aggressively. Obviously, if the patient has a history of seizures, if the patient has had a previous compression fracture, a seizure may lead to another compression fracture. So it depends a little bit on the patient as to when you would intervene in somebody who is not symptomatic, but whose serum calcium is very low. And I think all of you would agree that the IV treatment of choice is calcium gluconate, not calcium chloride, because of the fact that if the intravenous preparation were to extravasate into the sub-Q space, the calcium chloride is a much more irritating solution than is calcium gluconate. And you can really sclerose the subcutaneous tissue if the calcium chloride gets out. So we definitely favor calcium gluconate. And the way we do it is, as you know, the VAMPs are 10% calcium gluconate, which means that an amp of calcium gluconate will have 93 milligrams of elemental calcium. 2 amps will have 186, and you'll give it intravenously over a period of time. We never give calcium by a bolus. You don't take a syringe and just shoot it in. Actually, I did this once. I have to confess. I did this once. A patient came in, a well-known patient with hypopara, and didn't know better. So I just gave it like that. And the patient sort of stood up, sat up, and said, "Doctor, don't you ever do that again." And she was absolutely right, because you can stop the heart in systole if you give calcium acutely. So take your time, over 10 to 15 minutes. And that'll take the edge off the symptomatic hypocalcemia. And then, of course, you want to get the calcium up a little bit higher. So this is just one of the recipes to raise the serum calcium by 2 to 3 milligrams per deciliter. The recipe is 10 to 15 mg per kilogram, given intravenously in 1 liter of D5W over 6 to 8 to 10 hours. So if you take an example of a 70-kilo individual, if you're going to give 15 mg per kg, that means you need to give 1,050 milligrams. And if calcium gluconate is 10% calcium, that means only 93 milligrams of calcium per amp. You have to put in 11 amps of calcium gluconate. 11 times 93 will get you to 10,050. Okay? So you have to put 11 amps of calcium gluconate in a liter of D5W over 8 hours to bring the calcium up by 2 to 3 mg per deciliter. And this kind of calculation looks odd. And if you're a house officer and you're sleep deprived, but no house officers are sleep deprived anymore, right? They go home at 10 o'clock. That's an on-call schedule. They go home at 10. But in the days when they were sleep deprived, they would do this calculation and say, "Oh, I made a mistake. Can't be 11. It's got to be 1. I'm not thinking straight. It's 3 in the morning. So I'll give 1 amp or 2 amps, and then nothing happens. And then they call you, and you straighten them out. You say, "Well, you didn't give enough." Have you used this recipe? It works?
Yes.
Yeah. Now, is there an exception? What am I thinking question? There is a situation where you wouldn't give this amount in a person, and it has to do with the partition of calcium. Calcium is water soluble. Calcium does not go into the lipid phase. Okay? And so if you have a patient who's quite obese, where her body mass is more fat than lean, more of that calcium is going to stay in the intravascular space. So in people who are obese, I would cut this recipe down, because you'll raise the serum calcium by much more than 2 to 3 milligrams per deciliter. So just bear that in mind. Obese individuals, I would cut that dose by at least, I would say 50% to be safe. We used to do this at NIH. We used to, in the old days, we did these crazy things. We used to give calcium, intravenous calcium, to people with hyperparathyroidism. Why did we do that? Well, we were interested to know whether if you have a patient with a serum calcium of 12, if you raise it to 14, will you control the parathyroid? Is this an autonomous state or not? Well, obviously, it's got to be regulated in some way, or else the calcium would go through the roof. So even in hyperpara, by raising the serum calcium above the usual level, you can reduce the parathyroid hormone. And we learned our lesson by giving calcium intravenously to fat people. And we learned our lesson that that's not a good idea. Cut the dose down. All right. So chronic hypocalcemia. If you know the underlying etiology, you always want to pay attention to that. Obviously, oral calcium and oral vitamin D are the mainstays, until recently, of treatment of hypocalcemia. And we favor the carbonate because the calcium carbonate salt has a greater percentage of elemental calcium than the citrated calcium salt. That's why you have to give much more calcium citrate per pill, because there's less percentage of elemental calcium in calcium citrate than in calcium carbonate. And the other calciums are even less useful when it comes to the chronic management of hypocalcemia. We want to give vitamin D. And here's a situation where the guidelines, nutritional guidelines, are never enough when we're dealing with chronic hypoparathyroidism. We have to give much more, and we give pharmacological amounts of vitamin D. And that means we have some patients who are on 50,000 units a day, some patients who are on 100,000 units of parent vitamin D. And it goes to this point that if you give parent vitamin D in hypopara, yeah, you're gonna make a lot of 25-hydroxy, but you aren't going to convert. You're not going to convert it in the context of hypopara. Why? Because you don't have any parathyroid hormone to help convert to 125. These patients tend to be hyperphosphatemic, so you're going to inhibit, and this will override the effects of the low calcium. So you've got these two very potent stimuli that are not operative in hypopara. So you're depending on a lot of 25-hydroxyvitamin D to get an effect. And here's another situation where I don't care what the 25-hydroxyvitamin D is, as long as the calcium's okay. So, I mean, in my patients with hypopara, I have some who have levels of 100 nanograms per ml, 150 nanograms per ml, and it doesn't bother me because as long as I can control their calcium, I don't care what their 25 level is in the circulation, because you're depending on that pharmacological effect of the vitamin D for their situation. Hypopara is, the tense of this sentence has changed in the past couple of years, is the sole remaining classic endocrine disease, deficiency disease, for which the missing hormone was not available. And here are all of our endocrine deficiency diseases, and here are all our available and approved treatments. And now we can add recombinant human PTH1 to 84, which was approved by the FDA on January 23rd, 2015. The goals of therapy are to keep patients asymptomatic, to keep the serum calcium in the low reference range. Michelle is going to go over this in detail tomorrow. To avoid hypercalciuria, if you can. to keep the phosphate level below 6, if you can, to keep the calcium phosphate product below 55 milligrams squared per deciliter squared. Many of us want to keep it even lower than that. I think that 55 is much too high, but that's sort of the classic threshold. But we have patients who have calcium phosphate depositions in soft tissues, and they're predisposed to that, even if the calcium phosphate product is less than 55. But these are sort of the standard goals of treatment. Calcium, our patients have required as much as 9 grams per day. The use of 1,25-dihydroxy, vitamin D, calcitriol, you may need as much as 4 micrograms per day. The usual amount is 0.25 or 0.5 micrograms per day. And as necessary, the use of thiazides to control the hypercalciuria. And the central truth, in hypopara, many individuals either are receiving too much calcium and vitamin D or are receiving too little calcium and vitamin D. And in both situations, these patients are at risk for serious complications. So let's get back to our friend, parathyroid hormone. Teriparatide could be used for hypopara, has been used for hypopara, and the full-length molecule. So the rationale for this discussion is that what is missing in this disease? Parathyroid hormone. Teriparatide is not a natural product, I mentioned before. And moreover, for reasons that are not clear, teriparatide has a much shorter half-life in vivo than does the injection, if it's used as a drug, of subcutaneous PTH 1 to 84. Now, it is not clear why intact PTH has a much longer half-life, but you can use it once a day. But with teriparatide, if you're going to use it for hypopara, you have to use it at least twice a day, and some people say 3 times a day. So that is the rationale why some of us move to using intact PTH. But Karen Weiner at the NIH started and did some beautiful work pointing out that you can treat hypoparathyroidism with PTH, only she used teriparatide. And these are some of her nice papers that she has published on teriparatide in hypoparathyroidism. She's used it in children. In fact, her studies initially were children, and then she also has used it in adults. But here are the differences. Teriparatide, as I mentioned, is not the real thing, while 184 is. Neither one is a metabolic product. The effective half-life is longer with RH-PTH 184. And multiple daily injections, no, although there's some discussion now about maybe it would be desirable to give some of our patients more than 1 daily injection of the 1 to 84. But certainly the teriparatide needs more than 1 daily injection. And this is the famous study that we were involved in, the study called REPLACE, that looked at a group of about 130 patients with well-described hypoparathyroidism. This was an international study. It was randomized, double-blind, placebo-controlled, and it had 3 endpoints. The dose was 50 with a titration scheme up to 100 micrograms per day. The 3 endpoints, and this is very unusual for a clinical trial, all 3 endpoints had to be reached in order for it to be considered a success. There had to be a 50% reduction in the supplemental calcium requirements. There had to be a 50% reduction in active vitamin D requirements. And the serum calcium had to be maintained within the lower range of normal. All 3 endpoints had to be met by a given patient, or that patient will not have been said to have reached the endpoint. And then the secondary endpoint was what percentage of individuals could stop active vitamin D completely and reduce their supplemental calcium needs to only 500 milligrams per day. So here's a triple endpoint I mentioned before. And here are the results, which are kind of amazing. So in the blue bars, you see the number of responders as a function of this 24-week study. And you can see that the blue bars certainly dominate over the white bars, which are the ones who received placebo. 48 out of 90 of who got drug met this endpoint, while only 1 out of 44, there was a 2-to-1 randomization. So only one placebo and 2 drug was the randomization scheme. Only 1 made the endpoint. So 53% of the patients receiving drug met the triple endpoint and only 2% of the placebo group. And then in terms of the secondary endpoint, stopping all active vitamin D and getting down to calcium only 500 mg per day, 43% of those getting drug met the endpoint, while only 5% of the placebo group. And the serum calcium was maintained in the lower range of normal, as shown here. So in terms of our study, and I don't know whether Michela will be able to get into this with you tomorrow, but she just had accepted our paper that reports a 6-year experience of continuous use of PTH 1 to 84. This is the 4-year experience showing a reduction in calcium needs by about 50% over 4 years, a progressive reduction in supplemental active vitamin D without any major change in the serum calcium. Quality of life, Natalie Cassano has published on this. In all 8 domains of the SF-36 scale, the dotted yellow lines are the normative scale. In all 4 physical domains and all 4 mental domains, patients with hypopara scored below. They do not feel well in these ways. They talk about brain fog. They talk about a lot of things that really bother them. In terms of the effects of PTH on these components of the SF-36 scale, in green are the data 5 years after starting PTH 1 to 84. We have data 1 year out and 5 years out, and they're basically the same. So it's a sustained improvement with the exception of one physical component. It seemed like they improved. There's a paper that we're submitting very soon. Actually, Tamara is on this. She's the one who is involved in this. She's the first author in this paper. She's done this great work on quality of life in the pivotal clinical trial, which is going to say some things that are a little bit different, but it's a much more rigorous trial than this one. This was an open label, but our study that Tamara is working on was a blinded study, and it's a little bit more rigorous, but a little bit more confusing too. But the point is that these people feel better. They take up their bed and they walk. The brain fog lifts and they're whole again. They will tell you this over and over again. There's clearly something to PTH. And it isn't only getting the calcium normal. It isn't only getting the calcium needs to a reasonable amount. It isn't only stopping active vitamin D. Something about this hormone that affects the brain in a positive way. So the indications for RH-PTH 184, the FDA says in patients with hypopara who cannot be well managed with calcium and vitamin D. And I think Michelle is going to go into this in detail. By the way, there are 4 papers that are going to be published in the print version of the JCM in June next month. Those papers are online, so you can access them now. And they are the summary statement and guidelines for the management of hypopara. That's paper 1. And the next 3 papers are the evidence on which we based our new guidelines and how we interpret this sentence. What does well-controlled mean, and for what patient groups would you think that PTH 184 would be efficacious?